A lady woman, about 68 years old, that on August of 2014 had a diagnosis of localized advanced pancreatic cancer of the body. And from August to January of this year, she had treatment with Genzar. But at January, she started with celiac pain, and her CT scan showed a progressive disease. From January to March, she had 2 cycles of FOLFIRINOX, but as the pain increased, we proposed today celiac neurolysis guided by US that will be performed by Dr. Sahai and Dr. Boris.
The first thing to do is identify the celiac, which is the standard fashion. Okay, you want to be in a comfortable position. We've got the aorta here. Yeah, there's the celiac. You can see that if we follow the celiac, it's encased by tumor or node here, so you can understand why she has pain. And SMA, which is further down right there, is also sort of being pushed on by the lesion as well. So I favor the bilateral approach. There are some conflicting data from different randomized trials and retrospective studies, but I believe that based on the anatomy, it just makes sense to me that the more drug that you distribute all along here, where most of the ganglia are, the better it will be, more effective it will be, as opposed to putting it right here. The other thing I would say is that this issue of injecting the ganglia, I think the jury is still out on that. The only study that compared injecting the ganglia to what they called CPN actually didn't compare injecting ganglia here to just a bilateral approach. It compared injecting the ganglia, which as you know are more on the side here, to a central block. So I don't think the control group in that study was appropriate. So in the control group, actually, you got a response rate that was pretty much the same as we got in our response rate when we compared central to bilateral. So I think that study actually showed that a bilateral approach is better than a central approach. So what we need is a study that compares actually injecting bilaterally without injecting the ganglia versus injecting bilaterally and injecting the ganglia. And as I say every time, Mike Levy at Mayo Clinic has apparently done that study, and the data is in, but I still haven't seen any results. But he told me that study was finished about a year ago, and I still haven't seen the results. But I think that's the most interesting study, because they basically compared injecting here versus trying to do the ganglia and then injecting whatever was left all around at the base on both sides. So we'll have to see how that comes out. The other thing that I do, I think that is different from most people, is that I don't use any anesthetic, no bupivacaine. I think the important thing here is to get the concentrated alcohol on the ganglia, and if you inject the bupivacaine first, you just dilute the alcohol. And as I say, I think we'd give the bupivacaine more for the endoscopist than for the patient.
It's more to repair the site of injection, or maybe to decrease the post-operative pain, but no proof in the literature that an effect for that.
Yeah, and the patients are asleep, you know, and even if they have pain on the table, in our experience, they don't really remember.
Yeah.
The other thing was, interestingly, I was at another meeting, and the anesthetist told me that to him, one of the most dangerous things you can imagine is getting an intra-arterial injection of bupivacaine. He said that it's extremely hard to reverse, and he couldn't believe that we were doing this routinely because he thought it was so dangerous, you know? So that's maybe another reason not to use bupivacaine. I don't know of any cases reported of complications from that, but that was another reason to maybe not do it. So what I also do is I take a 19-gauge needle, so we're going to take the needle. So I take the regular 19-gauge needle. I prefer that to a smaller needle because if you're in a blood vessel, you know it right away with a 19-gauge needle, whereas with a smaller needle, you don't really know it necessarily. So I preload the needle with the alcohol, okay? No saline, no stylet, nothing like that. Je vous donne ça, ça va, wait. And I'm going to just put this in now. Now, there's a bit of an issue sometimes with the Pentax scopes and this 19-gauge needle. Sometimes it doesn't come out in front of the elevator. So you have to just kind of make sure before you do anything. Okay, I was lucky this time; it came out no problem. I could see the sheath right there, and you can see the needle right here. So I'm going to get into position here, and because we're using pure alcohol, I don't mind going through the gastric wall more than once because this is a pretty sterile procedure. For celiac block, where you're not injecting pure alcohol, but sometimes steroids and bupivacaine, there I think you want to make sure you go through the gastric wall only once because there is a risk of infection described there. But in this case here, sometimes I don't mind, instead of just going in at the base here, like immediately turning to the side to make the bilateral approach more easy. So I'm going to turn a little bit to the side already, put the needle right here through the wall. And you see here she's got a bit of tumor infiltration going all the way down to, where did my pointer go? Right down to here. So I got to be careful about that, okay? And what I'm going to do now is I'm going to ask you to aspirate. We're going to see if there's any blood. Aspire, oui, s'il vous plaît. Okay, that's good. No blood.
And you begin injection very close to the supramesenteric artery or very close to the celiac trunk?
Based more to the base of the celiac. So my tip is quite close to the base of the, of the SMA.
Just above the.
Yeah. So she's going to inject. You don't have to inject quickly, just nice and slowly. Oui, vas-y. So I didn't look for any ganglia or anything. And you know, about 30% of the time you can't see them anyway. And then I sort of withdraw a little bit as she injects. This patient is on
Alain, can I ask you a question?
In Canada, where we don't have propofol, when you're in the right place, the patients have quite a lot of pain. But as I say, they usually don't remember after that. So she's injected everything there. That's good. So we've done one side, okay? So now I'm going to try and do the other side. There is a bit of a blush with the alcohol. I'm going to pull the needle back here for a sec. So what happened to us in Canada was that we actually ran out of concentrated alcohol. So we started we started using phenol, and it was really interesting because I don't know if you ever tried, but phenol, first of all, is not painful. Second of all, it doesn't give you a blush, and I believe it's just as effective. So we actually ran out of phenol as well, so we're back to alcohol. But if you ever have a chance, I recommend you try the phenol. It's quite nice because I believe it also has a bit of an anesthetic property as well. So I've done this side, right? So if we're at the base here, I did this side. Now I'm going to do the other side. So I want to go right about in here. So I turn away, and I'm going to go through the wall again. There's no blood. Okay, it's
you have to avoid to inject in the tumor because of a risk of bleeding and.
And usually, if you're in the tumor, you won't be able to inject anyway. So.
Yeah. And
so
if you have a complete invasion of the celiac trunk by the tumor, it's a contraindication for me, it's a contraindication for neurolysis. If you have infiltration of the celiac trunk, it's a contraindication. You have to avoid it because you have risk of hemorrhage or necrosis, to increase pain in the tumor necrosis.
So we we don't have a lot of problems with hypotension after neurolysis, and it's one of those things we don't even tell the people to look for it. They never really call me for it. I do like to do a little bit of Doppler after doing this. I don't just only because we did describe a case of multiple infarction after a neurolysis. But even if it wasn't positive, I don't know what I would do anyway. There's nothing you can do, but it just makes me feel better when I go home. So you can see we've got what looks like a still permeable celiac trunk, which is good. And you can repeat this if needed. If they don't respond after about I'd give them at least a week. If after a week or so they haven't had good pain relief, I think it's reasonable to repeat it. I think it's very safe. There are complications described, as I say. We described one case of death after neurolysis. That was actually a potentially chronic pancreatitis patient. And if you look at all the complications, the major complications of celiac block and neurolysis, they're almost all in patients with chronic pancreatitis. So now I tend to not want to do neurolysis unless they have a proven diagnosis of cancer.
If you see the publication of recent case report of complication, hemorrhage, thrombosis, and some case of neurologic side effect
from EUS as well?
From EUS,
yeah,
yes.
Okay.
It's a rare description, but since 3 years there are some case report of severe complications with neuralysis. Very safe procedure with a very low rate of complication, but some 10 years ago we say no severe complication with this technique.
Yeah,
Probably
no, but
there
the more
are some,
we do,
there are some severe complications.
Yeah.
Less than with a radiological procedure, but there are some severe complications. Be careful to inject very close to as Dr. Sarai showed you, very close to the cellular trunk, but with very well knowledge
And I
of the
wouldn't inject
anatomy.
too fast either. I would also just say, we favor more and more early neurolysis. So we published a randomized trial. I think it was the only placebo or sham-controlled trial of EUS guided neurolysis, but it was actually in early neurolysis. So it was in patients who had little or no pain, who came for their EUS for diagnosis. And in that study, we showed that we really kept their narcotic consumption flat, and their pain scores were always better. So I don't think it should be used as a salvage procedure. It should actually be used more as one of the first things we do for pain in pancreatic cancer. I think we need more studies to confirm our results, but I think it seems like a good idea for now.
Of course.
How about the
Yes,
cook needle
so I think
indicated for
the
this
primary
procedure?
reason for, well, there's two. One, it's harder to inject, okay? It's really harder to inject, and especially when we were doing steroids for celiac block, it was very hard to inject. Two, it doesn't really spray out. If you take it out and try and push hard, it doesn't really spray. And three, if you're looking to see if you're in a vessel, I think it's much safer to do it with a big needle because you know you're in the vessel. With that needle, it's not quite sure you're in a vessel if you're in a vessel. And as I say, apparently injecting intravascular bupivacaine is extremely dangerous.
In your experience, we use a CPN needle because I have a habit to use it, and I think it's a habit of each operator. There are no difference, and but
You know that I'm the inventor of this needle, huh?
Really? Okay, so
problem.
now
I love you. I love you.
yeah.
No, it's no problem. Okay, we can change the room now.
Okay.
We move for the.
So I won't be ever coming back. So